I'd like to welcome special guest, Dr. Ankur Thapur, who is a senior research fellow at the Anglia Ruskin University and an honorary lecturer at the academic section of the Imperial College in Vascular Surgery. Thank you very much to doing this podcast.
Thanks, Anil. Thanks for having me.
So you've been a global leader in vascular surgery and involved with cutting edge, relevant research, including RCTs. Can you go over your trial looking at the use of compression stockings for acute DVT?
No problem. Along with several of my colleagues, including Professor Ellen Davies, Dr. Steve Black, and Professor Beverly Hunt, we recently completed the CHAPS trial. I think most of us know, after deep vein thrombosis, 50% of people will suffer lifelong disability. And because DVT happens to 1 in 1,000 people worldwide, this is an important burden of disability that's currently untreated. And we all thought ATTRACT was going to show big benefits for pharmacomechanical thrombectomy, but it really didn't show what we expected. And so the patients at the end of the day need something straightforward, which may or may not help them. And CHAPS looked to see whether stockings straight after DVT, with help for those patients to wear the stockings, would reduce that burden for them. And in the UK, our regulator, NICE, does not recommend stockings. The European Society for Vascular Surgery do recommend stockings. I believe CHEST doesn't recommend stockings. And so, multiple different guidelines are saying different things. And that's another thing we really need to help out with more evidence. So we're not the first trial looking at stockings, but there were important limitations in some of the other trials. So I'm sure you're aware of the SOX trial, which was a large trial from Canada. And before that, there was an Italian trial by Prandoni and a Dutch trial by Brandes. And subsequent to those, there's been a Chinese trial as well. And what I'll do is explain what happened in CHAPS, and then I'll explain when we put the results together with the other trials what we found. So in CHAPS, we took adults with their first proximal deep vein thrombosis, so that's at the popliteal vein or higher, and we randomized them to either standard anticoagulation as per the hematologist's advice, with or without elasticated compression stocking, giving at least 23 to 32 millimeters of mercury at the ankle. Now, what was different about CHAPS is that we sent patients text message reminders every day to wear their stockings. We also asked them to come in at 2 weeks to have a fitting done, because we know their leg changed shape in the first couple of weeks. Some of the edema moved. At the beginning of the trial, we showed patients an educational video about how to wear the stockings, how to use a donning aid, because some of the patients are elderly and it may be difficult, and also why we think the stockings might help them and how that might work. And so I think that was a missing part of the equation for a lot of people. And our idea was to try and get our adherence higher than in some of the other trials. And that was certainly a criticism of the SOX trial, that patients were not wearing stockings for more of the week than they were wearing the stockings, and they didn't find a benefit. So we wanted to avoid that problem. So our patients had to have their first DVT within 2 to 3 weeks, and they had to be able to live for the duration of the trial, so at least a year. If they already had post-thrombotic syndrome, they were excluded from the trial. Otherwise, it would become difficult to understand the results. If patients had palpable pulses, we didn't require any pressure measurements of their arterial flow before using the stocking. But if they couldn't feel a palpable foot pulse, we asked for an ABPI, which had to be 8 or more, 0.8 or more. So we randomized patients over 19 centers, and the assessors in the trial were blinded to whether the patients wore a stocking or not. Now, During the recruitment for CHAPS, we unfortunately had COVID, and we weren't sure how COVID was going to affect CHAPS because there were more thrombotic events. However, trials in the United Kingdom, which weren't to do with the COVID vaccine, were essentially shelved. And so we terminated CHAPS early. And so we should look at CHAPS essentially as a big pilot study to help us understand what the benefits of stockings could be. And we should also look at CHAPS in meta-analysis with other trials to really give us the numbers we need to understand what the results mean. So we randomized 150 people in CHAPS, and 111 made it to at least a 6-month follow-up. Our median follow-up was 9 months in the study. Okay, so what did we find? So we essentially found that the cumulative incidence of post-thrombotic syndrome halved. So in the control group, if we look at anyone with post-thrombotic syndrome, we found 51% of people develop post-thrombotic syndrome. So interesting, that figure hasn't changed with newer anticoagulants, with better treatment paradigms and more education, hasn't shifted at all. In the stocking arm, we found that 30% of patients develop PTS. So a large difference at an early stage at the sort of 6 to 9 month level. And in many of the trials, we find that a lot of the benefits for stockings are biggest at 6 to 9 months. And certainly that's something that we found as well. And some people have said that that might be due to adherence dropping off with the stockings after 6 months. So let's go on. So the other interesting thing is in CHAPS, we found no patient with severe post-thrombotic syndrome in the stocking arm. So again, something which was interesting. What did we find with regards to adherence? So our adherence, so we had 2 ways of measuring adherence. And we wanted something to help us with the patient-reported adherence. So we also looked at whether patients reordered stockings at 6 months. And so to be adherent with stockings, not only they had to report using the stockings, but they had to reorder them. And that's how we judged adherence. Essentially what we found is that people wore stockings for more than 80% of the time for about 6 to 9 months, and then things tailed off. And we found about a third of people discontinued stockings by 1 year. And that's something that we need to factor into the results of, I think, all trials looking at stockings, is that after the 6 to 9 month period, at least a third of people are going to stop wearing them. And perhaps that's why in big trials we see such an early benefit of stockings. So quality of life scores, interestingly, they didn't change hugely in the 2 arms, and I'm uncertain why that is. We don't have a good explanation for that. What happened when we put CHAPS together with the other 4 trials in this area? So we found a consistent risk reduction of over a third in post-thrombotic syndrome with the use of stockings. When we did our sensitivity analysis, taking one or either of the studies out, there are criticisms of some of the other studies, we found that this was robust. So the question really is, why do we think the SOX trial showed such a difference to the other 4 trials? And I think there are a couple of different opinions on that. We could start perhaps just thinking about how the SOX trial was designed. It was actually designed to investigate a drug in a factorial fashion with stockings. The drug never actually got to market. And so the investigators just carried on and did the stocking trial. But it was originally going to be a 4x4 grid, essentially. And so perhaps there wasn't as much incentive to really push the benefits of the stockings. It was essentially going to be a control arm for the drug trial. So that's something that is interesting to know. Secondly, adherence in the CHAPS trial, good adherence was judged as wearing stockings for about 3 days a week. And if you think about it, well, people are not wearing stockings for more of the week than they are wearing stockings. And that could be another factor. I think many people have criticized the Villalta criteria, but we have shown with 4 independent RCTs that the Villalta criteria do show a benefit in post-thrombotic syndrome reduction with stockings. So I don't think the criteria are at fault, but I don't think they should be used in isolation. I think we also have to look at quality of life measures. Now, since and hopefully the meta-analysis will hopefully be out later this year for everyone to have a look at, and hopefully to change guidelines. Now, since we've had the new data out from CHAPS and also from Yang, we've also had Ideal DVT out, and I think that's a great paper for patients. And Ideal DVT looked at whether patients could discontinue stockings early if on 2 clinic visits they hadn't developed post-thrombotic syndrome. And I think it's a big step forward because it means that for the majority of our patients, they could probably discontinue stockings within a year, maybe even 6 months. And we know that adherence beyond that time period starts to get affected. And we know that the biggest benefits of stockings are in the first 6 months. So I think the message that we are getting from all of the RCTs is that apart from CHAPS and apart from SOX, and even when we include SOX, is that there is a consistent 1/3 reduction in the risk of post-thrombotic syndrome with regular use of compression stockings. We definitely have to help people to understand why they use them, to fit them properly, to offer them a choice of the type of stocking they have, and to remind them to wear it. It's a behavioral change. And we know that most people can do that pretty well for about 6 to 9 months. And we know that luckily, most of them, that's all they'll need to use it for from Ideal DVT. So that's a great message. We know that without stockings, the risk of post-thrombotic syndrome has not changed in the last 30 years. It's still over 50%. It's a big, big number. Now, luckily, most of those patients have mild post-thrombotic syndrome. And perhaps the quality of life wasn't impacted as much as we thought because the benefits were mainly in mild post-thrombotic syndrome, just because there are more people with that. So that's one possibility. Yeah. So where do I think we're going from CHAPS? Well, I think we still have some patient groups which struggle with stockings. So people in really hot countries. So for example, there's never been a trial in Australia of compression stockings, and it just stands to basic principles that if it's a 30 centigrade, I don't know what that is in Fahrenheit, but you're sweating and you've got to go outside, how are you going to wear those stockings? And in CHAPS, we provided cotton stockings, but England's a cold country. How are the stockings going to work for people in hot countries? The second group is men. And so men can sometimes just be very resistant to wearing stockings, or they can just be uncomfortable, because men have hairy legs and it can itch. And when I wore compression stockings, it was incredibly uncomfortable. So I think we just have to be appreciative and understanding that there are gender differences and also geographical differences in other factors that we don't measure in trials. And these are something that you might need to consider when you're talking to your patients.
So can you just point out the funding source for the trial also, because people always question the results based upon funding sources?
100%. So this was a National Institute for Health Research, a health technology program grant, and it's entirely academic funded.
So I want to congratulate you because you really made it very clinically relevant and accessible. It's not something that um, is unattainable at most centers. We're all anticoagulating our patients and trying to figure out whether or not patients need to be using stockings. And I want to congratulate you because your body of work outside of this study has really focused on clinically relevant, hands-on questions. And I think this study, although it didn't necessarily finish with COVID, uh, get to completion, it really did give us some information as a springboard. And quite frankly, if I can reduce my post-thrombotic incidence in my patients and convince them that this is important, that to me even if it didn't run to completion, is still very important because of the what you were getting at the very beginning. The post-thrombotic state in my patients is a miserable condition, and emphasizing that to our patients is really important. And we don't have really good treatments to avoid the post-thrombotic state in our patients. We don't have good treatments for it, and the patients do suffer for it. What about the results with severe post-thrombotic state? I think you looked at that also in the study.
Yeah, so in CHAPS, we had 6% of our patients in the control arm developed an ulcer or severe skin changes. And in the control arm, and sorry, in the stocking arm, none of them did. So, I mean, small numbers, and we'll put the numbers from the meta-analysis out there as well. But in general terms, the big winners are the mild group in general terms. Just because there's more of them, I think, but there seems to be a big effect there. But I think it just I think the other thing just to be aware of from post-thrombotic syndrome, unlike the arterial patients who are generally retired, people who have post-thrombotic syndrome are usually of working age, so they're losing income, and that's a big difference. So we want to keep these guys employed, and so and they want to be employed because they're breadwinners. So I think that's another big difference between the deep vein patients and the arterial patients.
Again, I want to thank you for putting all of this together. This is a lot of hard work, and I want to just mention if you could just mention some of the problems besides COVID that you have with setting up these trials, initiating these trials, running these trials. There's a lot of trial and tribulation, energy, and hard work that you have to put into to run these trials. What were some of the difficulties besides COVID that you had with this particular trial?
Well, uh, CHAPS took a long time to get funded. So in the United Kingdom and even in cardiovascular research, deep vein thrombosis perhaps isn't the highest priority for the government. Maybe preventing deep vein thrombosis might be, but actually post-thrombotic syndrome wasn't a huge priority for the government. And it took us about 4 years to get CHAPS funded. So even just to get it off the ground was an amazing achievement for us. So we are so happy, and we're also incredibly grateful to the other trialists who supplied data for us to do the meta-analysis. And we've got trials from RCTs from multiple different countries now showing the same effect. And so I'm just so incredibly grateful to the other trialists for running those trials. And we can all pool our data and intelligently look at the data together and see what the message is for patients. I think the other thing, just to be, we very much thought about the funding stream for CHAPS, and we thought whether we should go down the route of having it as a industry-funded trial or academic-funded trial. And I think the message is, and for many trials, in this area, there are areas where both can contribute. So industry contributed stockings free of charge, which is a reasonable thing for them to do. And that's important for our patients because it gave them a choice of which stocking to wear. And if you're a man, you don't want to wear a bright pink stocking. And if you're a woman, maybe you don't want to wear a stocking which looks like a sports sock. But if flip it around, maybe it might work. And things like cotton stockings. So there needs to be an element where the people that offer the stockings give choice to the people, the patients in the trial. That really is going to help with things like adherence and things like that. But in general terms, it has shown us that these trials are possible, and the community in the world is all asking the same question after SOX. And to be honest, I think we've answered the question, and that's the most important thing. And it doesn't really matter how we got there and whose trial has the most numbers. It really just matters that we've pulled the data and we've shown virtually a consistent effect.
Thank you so much for this, going over this trial and all the work that you put into this trial. I'm really looking forward to some of the upcoming meta-analysis and such. And I'm sure the systematic reviews will also be contributory. So again, thank you so much for agreeing to this podcast. It was quite valuable.
Thanks, Anil. Absolute pleasure.